Good evening. Tonight we begin with something a little quieter and far more miraculous. The long, strange story of how humans learned to bend agony into unconsciousness. The entire history of anesthesia. Forget the neat composed scenes of modern operating rooms. For most of our past, attempts to dull pain were makeshift, risky, and sometimes brutally desperate. Herbs, fumes, opiates and rituals that could as easily harm as heal. The truth is, dropped onto a surgeon's table before reliable anesthetics, you wouldn't last through the first cut. Surviving surgery in those ages required a kind of endurance we can barely imagine. If you're enjoying this, take a moment to like the video and subscribe, and tell me in the comments where you're tuning in from and what time it is there. I'm always fascinated by the variety of places people are watching from. Silence your notifications, take a deep breath, and let's begin. Long before modern chemistry and hospital wards with electric lights, the human attempt to blunt surgical pain was an intimate negotiation between gardener and priest, apothecary and soldier, father and son. The instruments were blunt by our standards, bronze and iron, sharpened stones, a hand steady from years of repetition, but the primary allies against agony were not scalpels but scent and taste. Wine, bitter resins, leaves crushed to pastes, and the slow sticky creep of opium across a wound. In the river valleys and trading ports of the ancient world, knowledge of certain plants was catalogued and cherished because they changed the calculus of what a surgeon could try and what a village would allow. The opium poppy left impressions in Neolithic pottery and in the clay tablets of Mesopotamia. Its resin became both a comfort and a curse through the millennia. Willowbark, an old family friend of aches, sat alongside the more exotic mandrake and hemp in pharmacopoeias that crossed cultures and languages. People smelled the bitter tang of mandragora in dim rooms, measured wine by eye into a patient's mouth, bound straps across legs and prayed as much as they poured. In the Indian subcontinent, a written surgical tradition, most famously embodied in the Sushruta Samhita, outlined not only how to cut, but how to soften the cut for human flesh. The Sushruta material, redacted and compiled over centuries, perhaps as early as the first half of the first millennium BCE, and refined into the early centuries Common Era, detailed instruments and techniques with a sober pragmatism, and described the use of drink and sleeping draughts to render patients more manageable for operations such as nasal reconstructions and cataract couching. Those compounds were never purely pharmacological recipes. They were social tools. To administer a soporific in a village meant you were trusted to know how much to give, to time the incision, and to carry the patient through the fever that often followed. In these societies, as elsewhere, what counted as a tolerable operation was shaped by the available means of dulling sensation. When the remedy was a bitter wine mixed with crushed leaves, surgery was necessarily short, brutal, and highly selective. Wealth and rank, as much as medical need, decided who would brave longer procedures. Eastward, the Chinese pharmacological imagination named and described hemp and other sedatives. Texts that circulated in the Han Dynasty and later, some attributed to mythic figures like Shennong, list cannabis among useful plants, noting its cooling and numbing qualities. The physician Hua Tuo, who lived around 110 to 208 CE and moved in the violent currents of late Han politics, acquired a reputation that would outlive him. Later biographies credit him with a marvel called a mephason, a herbal brew, sometimes translated as numbing powder, supposedly used to calm and anesthetize patients for surgery. Stories of Hua Tuo's operating theatre mix the clinical and the mythical. By the later dynastic chronicles, the formula Tashola had already been lost. And scholars today argue over whether mephason was a true general anesthetic, a deeper sedative, or simply an effective analgesic combined with skillful technique. The caution of modern historians is itself a kind of reassurance. People then did not have access to standardized molecules and regulated doses, but they did have empiricism, substances tried, failures noted, remedies passed along with a name and a warning. In the Mediterranean, a long line of physicians, Hippocratic practitioners of the 5th and 4th centuries BCE, Roman surgeons like Aulus Cornelius Celsus in the 1st century CE, Pharmacologists like Pedanius Dioscorides and physicians such as Galen in the 2nd century CE kept lists of plants whose effects on the mind and body had been observed in taverns and battlefields. Dioscorides de Materia Medica catalogued resins and seeds that numbed and sedated. Galen experimented with compounding opium for fever and pain and shaped the therapeutic lexicon of the Eastern Roman world. Mandrake, with its tropane alkaloids, became a staple of surgical lore across the empire. Its reputation mixed pharmacology and folklore, for the same root that could dim pain could bring on delirium and dangerous cardiac effects. In that long Mediterranean corridor, wine was the most portable anesthetic, squirted into jaws, poured down throats, pressed into the mouth to keep a patient from biting his tongue. The Roman legions, moving across continents, carried not only instruments but recipes, and along with them a pragmatic ethics. Pain must be managed to keep an army fighting, but the means were improvisation more often than science. When the classical texts met the medieval world, the transmission of knowledge took on a custodial aspect. The great hospitals and medical schools of the Islamic world, Baghdad, Cairo, Cordoba, preserved and augmented Greek and Roman pharmacology. Al-Razi and Avicenna organised knowledge into compendia that would cross the Mediterranean and be translated into Latin centuries later. It was at Cordoba in the 10th century that Abu al-Qasim al-Zarawi, known in Europe as Abul Qasis 936 to 1013, wrote a surgical treatise that endured. His chapters described instruments and techniques, and they carried with them practical means of tempering pain. He and other Islamic physicians described the soporific sponge, an odoriferous bundle of linens and herbs steeped in narcotics such as opium and nightshade, and placed it beneath patients' noses, or even used resins pressed to the gums. That device would reappear across medieval Europe and last into the Renaissance, often in the hands of itinerant surgeons and barber surgeons who trusted soaked sponges more than theology. Europe's Middle Ages and the early modern period blended the old with something approaching experimentation. The manifold cookery of apothecaries in towns from Toledo to Toulouse refined mixtures. Laudanum, an opium tincture sometimes attributed to the alchemist physician Paracelsus, 1493 to 1541, entered the pharmacopoeia as a named remedy. Paracelsus himself was as much a rhetorician as a healer, insisting that chemistry belonged to medicine, and that tinctures and distilled waters could be more precise than humoral appeals. Ambroise Paré, the French barber surgeon of the 16th century, 1510 to 1590, embodied the change in practical strategy. He advocated ligatures instead of searing wounds with red-hot irons during amputations, reducing shock and infection risk, and he accepted the use of stronger sedatives where they helped shorten trauma. Yet even as techniques improved, operations were constrained by logistics. Armies demanded rapid amputations to prevent gangrene and save men for further fighting. Speed and order were the anesthetic's substitutes. Straps, assistance, a steady rhythm of incision and cautery, and, when available, a draught of wine or a sponge revealed in the palm of the apothecary. The rules of engagement for surgery were social as well as technical. Who could be operated on depended on the availability of sedatives, on the patient's social rank, and on the risk calculus of infection. A nobleman might be ferried to a better surgeon and given more elaborate soporifics. A soldier might be pinned to a table and cut so fast the trauma was a blur. In many pre-modern societies, pain itself carried moral freight. Suffering an ordeal could be a sign of piety, of endurance, but this did not mean compassion was absent. Rather, analgesia was an art of triage. If you could dull the edge sufficiently with an herbal wine and compresses, you did so. If not, you shortened the operation and stitched the rest with prayer. The unpredictable nature of dose and effect put a ceiling on ambition. A healer could make a patient drowsy enough to bear a wound or to endure a bone reset, but the deep, reliable unconsciousness that would allow hours-long abdominal surgery without a scream lay beyond the botanical horizon. With the Renaissance and into the early modern centuries, something shifted in the background. Apothecaries sharpened their tools, glass retorts and alembics became as essential as knives, and chemical thinking began to reframe the healer's craft. Distillation allowed tinctures like laudanum to be made with more consistency. The compiler of the London Pharmacopoeia, first edition published in 1618, attempted to offer standard formulas that could be practiced by apothecaries across a city now growing on maritime trade. Paracelsus's insistence that remedies be chemical as well as herbal opened a path for practitioners who saw themselves as both chemists and physicians, and it nudged pain management from ritual toward reproducible technique. Yet it was still a mixed economy of home remedies, church rites and professional compounding. Standardization crept in, but it arrived slowly. The great rupture of the late 18th and early 19th centuries came with the isolation of active substances from the plants themselves. In Paderborn, Germany, a young pharmacy assistant named Friedrich Wilhelm Serturner quietly performed an experiment that would change the scale of analgesia. Around 1804 he extracted a crystalline compound from opium, an alkaloid he would name morphium, after Morpheus, the god of dreams. The name would later anglicise to morphine. Serturner's work was revolutionary because it translated a messy, variable vegetable resin into a single molecule with a discoverable potency. He tested it on animals and then on humans, noting the concentration of effect and the dangers of overdose. His was not the last such discovery. Other chemists would soon isolate alkaloids from cinchona, from foxglove, from various seeds, and pharmaceuticals began to be thought of as discrete chemical agents rather than incantations in a jar. This chemical turn multiplied possibilities and risks. Laudanum and its ilk, once household liquors with a comforting bite, now had a soon-to-be-quantified enemy, the precise alkaloid. Morphine's arrival in the early 19th century allowed doctors for the first time to dream of standardized dosing, to imagine a pharmacopoeia where milligrams mattered. It also crystallized a social problem. When a drug is more potent and more transportable, demand and dependence follow. The 19th century would see opium traverse the globe in ways that altered geopolitics and family lives alike. British-controlled cultivation in parts of India supplied markets in Asia and Europe. The trade that fed sailors, soldiers and patients fed also addiction, and in the case of China, a diplomatic confrontation that erupted into the Opium Wars in 1839 to 1842. These were not just wars about commerce, they were wars that foregrounded how a single plant-derived drug had been transformed by chemistry and trade into a commodity that reorganized entire societies. The pharmacy chest in the early 19th century hospital looked different than it had a century before. Bottles labelled with tincture strengths and compendia with executing protocols began to circulate. Surgeons could give opiates to blunt pain after an amputation. They could prescribe morphine for the sleepless and the feverish. But chemistry's triumph was partial. These substances dulled suffering, but did not remove consciousness, consistently for surgery. The operational limits remained tactical. To convert analgesia into a reliable method for carrying out deep, long operations, one needed not only stronger drugs but a new delivery paradigm, which brings us, inevitably, to the air. The late 18th century had been a period of gas hunting. Scientists isolated and named a bewildering range of airs: oxygen, hydrogen, carbon dioxide and others. Joseph Priestley, working in the 1770s in England, was one of those chemists cataloguing the atmosphere. Among his discoveries he described a peculiar air that would later be called nitrous oxide. He noted its properties as a gas, but it took another mind to ask what that air felt like. At the end of the century, the idea of medicine from the air took institutional form when the Pneumatic Institution opened in Bristol in 1798 under Thomas Beddoes. Beddoes, earnest and reform-minded, wanted to explore whether gases could be therapeutic. He recruited a brilliant assistant, Humphrey Davy, a young scientist then in his 20s, who would go on to be one of Britain's most famous chemists. Davy's experiments at the Pneumatic Institution in 1799 and 1800 were meticulous in their curiosity and frank in their wonder. He inhaled nitrous oxide himself and recorded the sensations with a candour that sits oddly intimate in a scientific tract. The laughter, the welling joy, the numbness in the limbs, the altered perception of pain. He tested it on others, writing up observations in his 1800 monograph Researches, chemical and philosophical, chiefly concerning nitrous oxide, or dephlogisticated nitrous air, and its respiration. Davy did not hesitate to suggest clinical possibilities. He wrote that nitrous oxide had a surprising power to procure voluntary sleep and to diminish pain during operations or parturition. Importantly, he also noted the dangers, impaired respiration and the perils of excessive use, so his recommendation was cautious, not evangelical. There was an immediate irony to Davy's careful caution. The public reception of nitrous oxide favoured spectacle. The same properties that promised tacit comfort in a hospital, euphoria, laughter, brief detachment, made it an irresistible amuse-bouche for the period's lecture halls and private parties. The image is vivid in the travelogues and papers of the era. A violin stop, a baker's starched apron, a bladder full of gas passed around the drawing room, and guests collapsing into peals of laughter as if someone had turned the world's volume down and the colour popped. Entertainment and medicine tessellated in strange ways. Showmen and lecturers turned gas into a novelty, and that novelty both familiarised people with the idea that chemicals could induce altered states and trivialised the experience for some physicians who wanted sober study. There were, perhaps predictably, moral objections. Clergy and conservative commentators fretted at the spectacle of voluntary intoxication, at the idea that one could seek a painless oblivion for reasons of curiosity rather than necessity. Others worried that to remove pain mechanically would denature human character, that suffering had a theological or moral purpose, and that medicating it away was hubris. These anxieties echoed older ones about pain's role in virtue, but they would not stand in the way of technical progress for long. The science, too, had limits. Producing nitrous oxide required chemistry and apparatus. The gas had to be generated and stored in bladders or retorts and handed to a patient. There were no simple regulators, and there was the ongoing danger of respiratory compromise. Clinically useful anesthesia demands predictability, a consistent depth of unconsciousness, a controllable duration, and minimal systemic risk. Nitrous oxide offered a new model, a gas inhaled to alter sensation, but its short-acting euphoric nature made it less suited to long abdominal surgeries. For dentistry and short procedures, however, it was promising. And secondarily, perhaps more profoundly, the existence of nitrous oxide reframed the possible. Chemists now had proof that a man could go silent under the influence of a breath. Hospitals and inventors began to imagine devices and agents that could do so safely and for longer. In the arc from crushed leaves and wine to distilled tinctures and then to compressed gases, the history of pain relief is a story about logistics as much as it is about molecules. The early surgeon relied on local networks, the apothecary down the lane, the bead of wine in a bottle, an assistant's hand to apply a remedy. The pharmacist of the 17th century laboured with alembics to produce a reliable tincture for a whole town. The industrialising chemist of the early 19th century began to think in milligrams and in standardised bottles that travelled on ships across oceans. The pneumaticist of Bristol built retorts and tables and demanded a room where air could be measured. Each advance scaled the practice differently. The opium trade connected fields in Asia to drawing rooms in London. Morphine's isolation allowed hospitals to conceive of analgesic protocols. The inhaled gases required new furniture for medicine, bellows, bladders, and eventually regulators. And so the long night story of pain relief presses on. The ancients taught surgeons how to make do with plants and courage. Medieval and Renaissance practitioners preserved and refined techniques in an intermittent chain of continuity. The chemical revolution turned the old elixirs into substances with names and weights, and the new science of gases suggested an alternate technology of relief, one that would ultimately redraw the map of surgery. Each stage carried its ironies. Remedies meant to comfort could become habit-forming, spectacles could seed serious clinical innovation, and moral objections that began as resistance often softened in the face of undeniable practical benefit. The stage was now set. The trade in plants had ceded some authority to the laboratory. The public had been exposed to chemically induced insensibility with laughter and astonishment, and a handful of industrious men and women, shopkeepers, chemists, showmen, surgeons, were quietly building the logistical infrastructure that would allow the faint hope of painless surgery to become a routine promise. The story that follows is one of slow measurements and abrupt revolutions, of bedside compassion and factory production, and of the tireless human project to turn the unbearable into something tolerable. Diethyl ether had been a chemist's gentle secret long before it became a surgeon's ally, a volatile, sweet-smelling spirit that condensed on glass and made the eyes water when somebody heated a small flask in a laboratory. For decades it lived in the margins of scientific curiosity, an amusing reagent for the curious, a solvent in poorly ventilated apothecaries, an oddity in treatises on volatile oils. Humphrey Davy and other early investigators had already glimpsed the idea that gases and vapours could blunt sensation. Davy wrote at the turn of the 19th century about the analgesic possibilities of nitrous oxide and of gases more generally. Yet chemistry and clinical practice are different trades, and for the large world of surgeons who measured skill by the speed of their blade, the notion that a patient might be made insensible before the incision remained, for many, a speculative oddity rather than a path worth following. That quiet world changed very quickly in the autumn of 1846. On a clear morning in Boston, in a smoke-stained amphitheatre at the Massachusetts General Hospital, a curious convergence of chemistry, dentistry, and showmanship produced a moment that would be called revolutionary. William Thomas Green Morton, a Boston dentist with a taste for practical experiments, stepped forward with a small glass inhaler and a sponge soaked in ether. The surgeon, John Collins Warren, stood ready with scalpels and curious colleagues packed into the gallery. The patient, reported in contemporary accounts as Edward Gilbert Abbott, lay on the table with a neck lesion that, by the standards of the day, would have meant a lightning-fast incision to spare the patient the ordeal of screaming through a protracted operation. Morton placed the sponge to Abbott's face, and the pungent, sweet vapour rose into the room, an odour like fruit and solvent and wintergreen, familiar to chemists, strange to men who had been used to chloroform-free air. Abbott's eyelids drooped. The scalpel came down. The cut was made. The surgeon worked at a tempo now unhurried, deliberate. There were no shrieks. There was instead an almost obscene civility, a hand that could take time. When the wound was dressed, the patient was roused. He awoke with only the faint memory of being elsewhere. The gallery, which had expected spectacle, gave a different kind of response. Silence, then tentative applause, then a flood of disbelief and joy. The place where it had occurred later became known, with a kind of pious irony, as the Ether Dome. What Morton had done that October day was less a single technical miracle than the announcement that a laboratory spirit could be turned into a surgical instrument, portable, repeatable, and radical in consequence. Ether's physical properties made it workable in the theatre. It vaporized readily at room temperature. It produced a reliable and deep state of insensibility when inhaled in sufficient concentration. And, contrary to many earlier agents, it did not prevent a surgeon from proceeding cleanly once the patient was relaxed. The effect was immediate and social. News of the demonstration spread not slowly, as such news often had in the era before telegraphic dispatch, but fast. Word travelled to New York and Philadelphia, London and Paris. Within weeks and months, surgeons were writing letters, travelling to see demonstrations and rearranging their theatres. The logistics were transformed. Tables that had been instruments of speed became places for longer, more complex craftsmanship. Teams of assistants were required to manage inhalers to keep sponges saturated, to watch the patient's breathing and pulse. Pharmacies had to stock ether in new quantities. Distillers and chemists scaled up production. Overnight, operations that had been impossible except in desperate hands now appeared within reach of technique. The repertoire of surgery lengthened because the surgeon could take time to see, think, and reconstruct. History loves tidy firsts, and so the moment in the ether dome became the image of a revolution. The reality was messier. claims of priority gathered like flies. In a rural town in Georgia, Crawford Williamson Long had used ether on March 30th, 1842, to remove a small tumour from a patient. He made notes and later recollections, but that he did not publish until 1849, which meant the world at large did not know him as the public discoverer. Horace Wells, a Hartford dentist and an early advocate of nitrous oxide for painless tooth extraction, had demonstrated his technique to scepticism and ridicule in 1845 when a public showcase went badly and he returned home discredited and embittered. Charles Thomas Jackson, a Boston physician and chemist, claimed that he had told Morton of ether's properties and accused the dentist of claiming credit. Morton, for his part, had complicated the moral landscape by trying to secure a commercial term, lithion, for his preparation and seeking financial reward for his discovery. The fight over who could legitimately claim the first word in anesthesia became as dramatic as the clinical work itself. Courts, newspapers, and personal enmities all had their say. There was no single inventor who could be trimmed out of the longer social process that had made anesthetic surgery possible. Morton's public demonstration, however theatrical, had the decisive property of publicity. It made what others had tried into something that the surgical world could see and imitate immediately. The clinical consequences were both exhilarating and destabilizing. Surgeons found themselves able to think beyond the one-act drama and toward multi-stage operations. Abdominal exploration, hitherto suicidal for many reasons, became imaginable in the context of a willing patient. Surgeons could take time to bind, resect, and suture in ways they had not permitted themselves before. The logistics of theatre changed too. Theatre teams expanded, assistants were trained to regulate ether delivery, and supply chains for distilled ether were woven into hospital procurement. At the same time, these changes exposed the weak link that remained in mid-century practice: infection. Anesthesia removed the immediate agony, but it did nothing to stop the microbial poisons that followed careless hands and unwashed instruments. Paradoxically, anesthesia's liberation of the surgeon's time, its most humane consequence, contributed to a surge in operations that, without antisepsis, sometimes produced appalling post-operative infections. The surgical revolution in that sense was a two-act play. The first act, immediate and dramatic, was anesthesia. The second, antisepsis, was to come later under Joseph Lister's influence. For a time, the new ability to cut more freely simply meant more people lived long enough to suffer the subtler consequences of invasive surgery. The public response was part gratitude, part incredulity, part moral speculation. Newspapers ran accounts in plain prose that hardly masked wonder. Cartoons and jokes followed quickly. Surgeons, suddenly rich in leisure time, amateurs imagining painless pranks. But there were also earnest voices of dismay. Some churchmen and moral philosophers argued that pain, particularly in childbirth, had theological meaning. To remove it wholesale could be to interfere improperly with providence. Others argued for the simple mercy of relief. For the vast majority of patients, the question was practical. Would this strange-smelling vapour allow them to survive an operation without the agony they had been told was necessary? The answer, increasingly, was yes, and with a speed that made debates about priority seem minor beside the immediate human relief in a surgical bed. If diethyl ether carried the first public movement of anesthesia into the operating theatre, chloroform was the second instrument in a clinical duet, and its arrival reshaped both practice and politics. In 1847 in Edinburgh, James Young Simpson, a young obstetrician with a contrary streak and a taste for experimentation, and his medical colleagues sat around inhaling a new chemical, chloroform, and promptly passed into a deep dreamlike insensibility. Simpson saw, perhaps more clearly than most of his peers, a special application for obstetrics. Chloroform provided deep analgesia and sedation with less of the coughing and throat irritation that could accompany ether. It was readily available, volatile in a different and heavier way, and, because it did not burn, was immediately attractive in theatres where open flames were present. Simpson became an evangelist. He wrote, lectured and persuaded colleagues to try chloroform in labour wards and on surgical tables. He did so with a missionary's zeal, arguing that to ease a woman's travail was in fact a moral good and a professional duty. That claim, however, sat in a field of cultural resistance. Many held firmly to an older script, that childbirth pain was a natural chastisement, a theological chastening, a rite through which women had always passed. To offer an artificial cushion against this elemental suffering risked being accused of moral collusion with softness. The argument was not purely clerical. It carried social undertones about the proper place of women, about stoicism and character. What changed the tone of the debate in Britain was an unlikely instrument of royal example. In 1853, Queen Victoria, following Simpson's campaigns and the careful work of the London physician John Snow, accepted chloroform during the birth of her son, Prince Leopold. Snow, an English physician who applied a scientist's mind to the problem of anesthetic administration, had designed inhalers and methods for measured dosing, and argued publicly for regulated, cautious use of these potent vapours. He was not merely an advocate. He built apparatus and protocols meant to limit overdose and to keep careful watch on respiration and pulse. When he administered chloroform to the Queen, doing so with the gravity of a court physician and the precision of a man who had measured vapours and watched their effects on dozens of patients, the message that pain relief could be both proper and royal reached far beyond Edinburgh's lecture halls. John Snow's contribution was as much procedural as rhetorical. At a time when open-drop methods, dripping a volatile liquid onto a handkerchief or a sponge and holding it to the patient's face were common, Snow sought measurement and repeatability. He designed inhalers with valves and reservoirs, and he translated his observations into rules, small incremental doses until the patient quieted, constant attention to the rhythm of the breath, readiness to stimulate or reduce the agent, patience. He published his findings and his apparatus in detailed treatises, and he insisted that competence mattered. Snow's technical rigour contrasted with the more ad hoc practices in many provincial clinics, and with the spectacle of public demonstrations. He argued, quietly but insistently, that anaesthetic administration was not a matter for theatrics, but a therapeutically delicate intervention that demanded training. The public, though, cared most for the image. The monarch's comfort was proof enough that chloroform was not merely tolerable but civilised. In the decades that followed, Queen Victoria's use of chloroform would be recalled more than the chemical debates over which agent was chemically superior. Not every introduction was serene. Chloroform's virtues, non-flammability, deep potency, came with dangers that the first decades had not yet fully measured. The deaths that followed chloroform administration, sometimes sudden and unexplained, produced coroners' inquests and public alarm. Hannah Greener, a 15-year-old English girl, died in 1848 during dental extraction after inhaling chloroform, and her case was widely reported. The inquest and subsequent commentary forced the profession to reckon with the fact that these vapours could, in certain instances, stop the heart without obvious warning. The balance between relieving pain and risking mortality was a public conversation as intense as any political dispute of the period. The mid-century physician's answer to that balance was, again, procedural. Better inhalers, better watchers, clearer guidelines on who should administer, and a growing insistence that anaesthetic practice required a distinct body of knowledge. That insistence is the bridge to the slow institutional work of building anaesthesia into a recognised practice. A transformation driven by pioneers with different temperaments and different tragedies behind them. Horace Wells is the first figure most chroniclers name when they want to speak of the personal courage of early adopters. A Hartford dentist, he had noticed nitrous oxide's effects in public demonstrations of the 1840s, and after a personal test in 1844, began to use it to extract teeth. His was a pragmatic decision. If a simple gas could spare a patient a scream and the teethman his hurried blade, so much the better. His public demonstration, however, famously failed, and the ridicule that followed haunted him. Wells's later life was tragic. Professional rejection and personal despair ended with his death. His story forms a moral counterpoint to Morton's public triumph. Discovery is often lonely, and the rewards of fame are not evenly distributed. Morton's own trajectory did not end triumphantly either. The legal wranglings with Jackson, the nervous attempts to patent Letheon, the public disputes over credit, and the refusal of government bodies to grant him a summer for his discovery left him embittered. He died in relative obscurity. The human drama of these men matters because it shows how medical advances in the 19th century were not only the fruit of laboratory experiments but also of social capital, publicity, and the messy commerce of recognition. By the latter half of the century, however, the activity of delivering anesthetics had begun to be recognised as its own craft. Joseph Thomas Clover, an English physician working at St Thomas's Hospital in London, embodied the professional turn. Clover, who lived from 1825 to 1882, took the new responsibilities seriously. He observed carefully, he wrote manuals, and he invented mechanical aids that would become standard. His chloroform inhaler, the Clover inhaler, developed in the 1870s, allowed a measured, gradual supply of chloroform and helped prevent the sudden administration of excessive doses. He collected statistics, he published case reports, and he saved many lives with quick, practical responses to airway obstruction. Clover's career illustrated the transition from ad hoc gas dispensing to methodical practice, watching the chest, counting the breaths, palpating the pulse, having stimulants at hand, brandy and ammonia, odorous salts and the crude stimulants of the day, and above all, anticipating the critical moment when the patient's breathing might falter. The tools themselves were humble in the early decades. The open drop method reigned in many places. A sponge, a handkerchief, a metal mask. Hospitals improvised reservoirs and tried glass bells and rubber bags. Snow's valves and Clover's regulators were incremental improvements layered on simple beginnings. There were no standardised machines in the 1840s, the way an operating theatre 2 generations later would have them. Instead, there were dozens of local inventions and practices, each adapted to the available supplies and to the temperament of the clinician on duty. That multiplicity bred both innovation and hazard. In some town hospitals there would be a skilled practitioner, often a dentist turned anesthetist or a physician who'd paid special attention, while in others a careless assistant or an anxious undergraduate would be in charge of the gas. It was not surprising that the public and the medical profession demanded measures to control who might open the valve. Public debate, meanwhile, oscillated between wonder and horror. Theatres that had once been public spectacles of agony were now quieter. The lack of outcry sometimes troubled people, who saw the surgical theatre's old rawness as a moral cleansing. There were satirical takes. If one could remove pain, what then of virtue? There were also pecuniary motives. Some providers of anaesthetic apparatus or of distilled ether tried to profit from their monopoly, while others gave generous demonstrations. The business of anesthesia was not merely technical, but commercial. Supply chains had to be built, and hospitals had to budget for the new, regular expense of volatile agents. This tension between the new requirement for careful, continuous observation and the older model where the surgeon ought to finish quickly was perhaps the most consequential. As operations grew longer, the surgeons were no longer racing against the clock of pain. They discovered new complexities. They needed steady hands hours into an operation, assistants who could think and not merely hold, and an observer whose sole duty was to the patient's breathing and circulation. The idea that a specialised practitioner should be responsible for that task took time to be entrenched. In Britain and the United States, the specialist anaesthetist gradually emerged in the late 19th century from this practical necessity. Men like Clover and Snow, who took the bedside and the inhaler seriously, became exemplars. Hospitals began slowly to recognise the value of a dedicated role. The first formal societies and chairs came later, but the pattern had been set. Anesthesia could no longer be incidental. It required training, apparatus, and the patient attention that comes from seeing something as one's entire responsibility. Alongside professionalisation, there were also legal and regulatory ripples. Coroners' inquests after catastrophic losses produced recommendations and, occasionally, temporary restrictions. Medical journals debated rules. Who should be permitted to administer anesthetics? What were the requisite qualifications? John Snow had argued that a practitioner needed both anatomical knowledge and a sense of precise dosing. Others argued that a good surgeon was naturally the one best placed to judge depth of anesthesia. In time, the sheer technical need for continuous respiratory monitoring, an art best learned without the distraction of wielding a scalpel, won out. By the end of the century, in the great hospitals of Europe and America, anesthetic practice had left its ad hoc origins and taken on the outlines of a profession. Manuals, classrooms, apprenticeships, and in time, formal exams. The path from an ether-soaked sponge to the mature anesthetic specialty was thus neither straight nor simple. It involved chemistry and commerce, spectacle and quiet hands. It involved the energetic evangelism of obstetricians like Simpson and the careful measurement of clinicians like Snow. It involved the painful public lessons of early deaths and the private labours of men and women whose work was to keep a patient breathing while someone else cut. It involved social debate about mercy, about providence, about the dignity of pain, and the slow institutional response that turned a novelty into an expectation. By the middle decades of the 19th century, a patient could enter an operating theatre with a very different future than had existed a generation earlier. There would be no need for the shrieks that had formerly echoed through surgical amphitheatres. There would be, instead, a small apparatus, a hand on a breathing, a soft chemical scent, and a professional whose job it was to shepherd the patient gently through the interval between consciousness and the other side of the cut. The story of those years is not merely a line of names and dates, but a shift in scale and strategy. The surgeon's triumph of technique that the 19th century often celebrates was not simply the blade's triumph, but the result of a rearrangement of operating theatre logistics. Longer teams, steadier supplies of volatile agents, new mechanical devices, standards of observation, and the cultural sanction that a monarch's comfort could confer. That rearrangement is the heart of the surgical revolution, inaugurated in the Ether Dome and carried forward in obstetric wards and quiet theatres across Europe and America. What began as a chemist's curiosity became, before the century's middle, an indispensable tool of medicine, and in doing so reshaped how society thought about pain, responsibility, and the limits of professional practice. The late 19th century opened a new corridor in the House of Pain, not a door that let the patient slip entirely into oblivion, but a series of windows and shutters that could be closed around a limb, a nerve, an eye. In 1884, a young Austrian ophthalmologist named Karl Koller, working in the glassy lamp-lit wards of Vienna and listening to ideas bouncing among surgeons and psychiatrists, placed cocaine on a cornea and watched a surgical field go quiet. It is a simple image, a drop, a blinkless eye, a scalpel, yet its consequences were vast. Kohler's demonstration that a chemical applied locally could abolish sensation at the surface of the eye without sedating the mind resonated like a small bell in every theatre where knives and pain met. Sigmund Freud, who had been experimenting with the stimulant and analgesic properties of cocaine in the same city, had rubbed at the molecule's edges in print and experiment. Koller put it into a surgeon's palm and changed what surgery could ask of the human body. The first uses were unglamorous and precise. Topical cocaine for corneal operations, peribulbar infiltration for cataract work, small rings of numbness around eyelids and conjunctivae that let surgeons operate without general anesthesia. Cocaine had virtues the ether bottle did not. It constricted vessels, reducing bleeding, spared the lungs, it left the patient awake, a conscious witness to the miracle of a pain-free touch. The physiologists scratched their heads and the surgeons cheered. America's surgical ateliers were quick to experiment. William Stewart Halsted at Johns Hopkins allowed himself to be as curious and as reckless as pioneers often are. He tested peripheral nerve blocks, used cocaine for infiltration, and paid a private price for his zeal in the form of addiction, illustrating, with a dark irony, that a medicine that spared the patient's body could take the caregiver's balance. Not all early experiments were neat. In 1885, James Leonard Corning, an American neurologist, published on lumbar injections of cocaine intended to produce anesthesia of the lower body. Corning's technique predated the now standard spinal punctures, and historians have argued whether, in the language of the time, he had entered the subarachnoid space at all or had placed his solution in what we now call the epidural region. He described the transient leg weakness and sensory loss attributed to local action on spinal nerves and thus opened an idea. If you could reach the spinal cord's roots, you could numb halves of the world below a puncture. Heinrich Quinker, a German clinician, later designed a needle and described a technique for lumbar puncture in 1891 that would become the technical key. Once the cerebrospinal space could be entered with some reliability, the notion of a spinal anesthetic moved from hypothesis to practical experiment. August Beer, a German surgeon with the kind of scientific appetite that made the late 19th century both exhilarating and a touch dangerous, embraced the challenge. In Kiel in 1898, he performed the first controlled spinal anesthesias using cocaine injected into the subarachnoid space. Beer experimented with patients, and in a gesture part showman, part researcher, anaesthetized himself and his assistant to map the sensations and the side effects. They felt numbness travel up their bodies, and later they developed the now familiar post-dural puncture headache that seems, to the modern ear, a cautionary lullaby from the spine itself, a reminder that penetrating a delicate membrane carries consequences. Beer's accounts were meticulous, sometimes disquieting, and they gave the world the vocabulary of spinal anesthesia, the idea that surgeons might leave the brain untouched, the lungs free from vents of ether, and yet still render entire regions insensate for operation. Those technical breakthroughs were born of experimentation, but they rode on a steady sheet of physiological observation. Clinicians noticed patterns. Small myelinated fibres carrying pain succumb to local anesthetics earlier than large motor nerves, which is why patients often experience numbness or loss of pain with preserved movement, or conversely a careful balance where motor block and sensory block could be tuned by dose and site. They observe systemic toxicity, mostly cardiovascular and central nervous system effects, when cocaine was absorbed into the circulation. They learnt the hard way that what numbed the cornea could, in larger measure, constrict heart vessels and provoke tremors, seizures, or worse. The laboratories of the early 20th century began to pull chemistry towards safety. Alfred Einhorn in 1905 synthesized procaine, better known to patients as Novocaine, a synthetic ester of lower systemic toxicity and without the addiction potential of its natural predecessor. It was a tidy European solution. A chemist gave surgeons a less dangerous blade edge on which to hang their experiments, and the world of dentistry, of obstetrics, of orthopedics took notice. Nerve blockade techniques matured in the slow, careful manner of an art being honed. Brachial plexus, femoral, sciatic, and other peripheral blocks came into the repertoire through a combination of anatomy, patient reports, and clinical daring. A needle, a prick of paresthesia as the tip brushed a nerve, a slow injection, a growing numbness like a tide. Methods for locating nerves improved. The old-fashioned paresthesia technique was later supplemented by electrical nerve stimulators in the mid-20th century and by ultrasound guidance in the late 20th and early 21st, but the core idea remained the same. Put the agent beside the nerve and the pain stops there. The epidural space, occupied by fat venous plexuses and spinal roots, became an essential theatre of operation. James Corning's early injections were followed by more formal descriptions, but it was Fidel Paget, a Spanish military surgeon in 1921, who published a practical technique for lumbar epidural anesthesia, peridural as he called it, that later generations would recognise as foundational to obstetric analgesia. The consequences for perioperative risk were immediate and profound. Regional techniques allowed surgeons to shrink the use of full general anaesthetics. They reduced the need to depress cardiac and respiratory centres with ether or chloroform. They allowed operations on fragile patients for whom a general anaesthetic might be a nearer threat than their surgical disease. For childbirth, Where general anesthesia had been dangerous because of aspiration and bronchopulmonary complications, the epidural presented a calmer horizon. Pain could be markedly reduced while the mother's airway and consciousness were largely preserved. That change redistributed risk. It traded the dramatic system-wide danger of an ether overdose for a localized but still serious set of complications. Accidental intravascular injection leading to seizures and cardiovascular collapse, high spinal blocks that climbed too far and interfered with respiration, spinal headaches that could leave new mothers doubled over with pain for days. Yet, when practiced with care and an understanding of anatomy and dosing, regional techniques reduced mortality and improved the quality of recovery. As the century turned and clinicians learned more about the nerve itself, chemistry again responded. Procaine would give way to amide anesthetics. In D43, Swedish chemists synthesized lidocaine, a more potent, faster-acting, and less allergenic molecule that quickly became ubiquitous. These new agents were metabolized differently and offered more predictable durations. Pharmacology deepened its conversation with physiology. Sodium channels within axonal membranes were proposed as the molecular targets that allowed anesthetics to arrest impulse conduction. The full biochemical verdict would come slowly, with mid-20th century electrophysiology and the Hodgkin-Huxley work on ion channels, but the clinical clues were already clear. A block placed correctly could allow a surgeon to fashion a limb or extract a cataract while the patient watched, or slept, or whispered to relatives in the next chair. What had been unthinkable, surgery without rendering memory and sensation universal, became normal practice in many theatres. The advances were not simply technical, they were social and structural. Operating suites reconfigured themselves around the idea that anaesthetic care was no longer a one-size-fits-all sedation, but a spectrum of targeted tactics. Hospitals appointed specialists to manage regional anaesthesia. Nursing staffs learned to watch for signs of local anaesthetic toxicity and for the telltale chest and facial blanching of intravascular injection. The field of anesthesiology began in visible ways to define itself by competence in these localized arts. To be an anesthetist was to be a guardian not merely of sleep but of regional calm. If regional techniques moved the surgeon's knife away from the necessity of spoiling the mind, another set of discoveries attacked the problem of muscle itself. For certain operations of the opening of the abdomen, the exposure of thoracic cavities, the neat work of an orthopedic saw, stillness, not just insensibility, was necessary. Surgeons had long had to cope with reflexive movement and spasm. The answer came from a poison whose history reaches into rainforests and into the very narratives of encounter: curare. Europeans first encountered curare through accounts from South America, where indigenous hunters used it on arrow tips to immobilize game. To physicians and physiologists, it arrived as an object of terror and of fascination, for here was a substance that could render a living animal utterly limp while leaving the eyes bright and the heart beating, a paralysis without the apparent loss of mind. Claude Bernard, the great French physiologist of the mid-19th century, was the clinical mind who turned curare into an instrument of physiological insight. Bernard's experiments demonstrated that curare blocks transmission at the neuromuscular junction. Nerves could still transmit a signal into the muscle's vicinity, but the muscle did not respond because the poison prevented the signal's action on the muscle membrane. Bernard's work was elegant and chilling. Curare taught physicians that motor output could be dissociated from sensation and consciousness. The implications for surgery would wait for the next wave of chemical and clinical advances, but once isolated compounds such as tubercularin were purified and made available in the early 20th century, the stage was set. Clinical adoption of plant-derived alkaloids took decades of trial and error. The turning point, the moment when curare moved from laboratory oddity to operating room tool, is commonly dated to a wartime and wartime-adjacent medical world hungry for improved techniques. In 1942, the Canadian anesthesiologist Harold R. Griffith and his colleague Ina Johnson reported the use of D-tubercurin to produce muscle relaxation during anesthesia. They administered the drug to surgical patients and watched, for the first time in an orderly way, the marvel and terror of paralysis used deliberately. Surgeons could operate with a quiet field. Anesthetists could reduce the depth of hypnotic agents because motor immobility was now pharmacologically enforced rather than chemically coerced via deep benzodiazepines or excessive ether. This is the moment when balanced anesthesia, a concept more than a slogan, became clinical orthodoxy. To render a person unconscious, free of pain and motionless, clinicians now combined hypnotic drugs, analgesics, and neuromuscular blockers. Each element carried its own profile of effects and dangers, and the balance among them became both art and protocol. The pharmacology was, in one sense, beautifully simple. Tubocararine and its cousins act as competitive antagonists at the nicotinic acetylcholine receptors at the motor end plate. Where acetylcholine normally binds and opens a channel that depolarizes muscle, Curare stands in the doorway and refuses entry. The diaphragm fails to contract. Consciousness remains intact because these alkaloids, being charged quaternary ammonium compounds, do not readily cross the blood-brain barrier. The net result is the cruel clarity of paralysis. A patient who feels, perhaps even remembers, but cannot move a finger. The anaesthetist's responsibility grew. Airway control became non-negotiable. To give paralysis without a guarantee of ventilation was to flirt with death. That imperative catalyzed a cascade of practical innovations. Endotracheal intubation, once an occasional solution for airway obstruction, became a routine skill in anesthetic practice. The techniques for bag mask ventilation, for tracheal tubes and cuffs, for rapid sequence induction, all the choreography of keeping the paralyzed patient alive, matured in the shadow of Curare's adoption. The profession of anesthesiology was pushed towards standardization. Drugs were timed, equipment was staged, and monitoring, crude by later standards but nonetheless life-saving, grew into a discipline. The presence of a neuromuscular blocker in the anesthetic plan meant that someone sat at the head of the patient, watching chest rise, listening for breath, ready to ventilate with bag or machine. Tubocararine was not perfect. It had hemodynamic consequences. Histamine release could produce hypotension, bronchospasm occurred in susceptible patients, ganglionic blockade could disturb autonomic reflexes. Its duration was long enough that prolonged paralysis could be a hazard, especially when renal or hepatic function delayed elimination. Thus, the pharmacological world choreographed a succession of molecules. The mid-20th century saw chemists and pharmacologists designing synthetic neuromuscular blockers with different onsets, durations, and side effect profiles. Decamethonium and other depolarizing agents appeared, and then the famously useful succinylcholine, a rapid-onset, short-duration depolarizing blocker, found its niche in rapid sequence intubation and in short surgical procedures because it produced a burst of paralysis and then spontaneously hydrolyzed. Non-depolarizing aminosteroid and benzylisoquinolinium compounds, pancuronium, vecuronium, rocuronium among them, provided longer-acting, more predictable neuromuscular blockade without the same histamine profile, and educational and pharmacological systems developed to reverse their effects reliably using anticholinesterase agents like neostigmine. In the finitude of decades, the surgical world had at its disposal a palette of neuromuscular tools. Short, long, steroidal, depolarizing, reversible. Every advance in muscle relaxation pushed anesthesiology further away from the lone apothecary and toward multidisciplinary vigilance. The surgeon's expectation of stillness demanded an anesthetist's guarantee of respiration. The operating theatre became a place where one person's breath, delivered by hand or machine, was a life-sustaining art. There is a dark humour here, learned by generations of trainees. Surgeons, accustomed to stern silence, trusted a slender, dark-suited colleague to keep their patient breathing while they sawed or sutured, and the anaesthetist became, with quips and calm, the ultimate arbiter of life under the blade. The 20th century's closer turned again on chemistry when hypnotics moved from vapours into the bloodstream. Intravenous induction agents allowed a different kind of control, immeasurably rapid loss of consciousness, with more titratable dosing and often faster recovery than inhaled agents could manage alone. Sodium thiopental, a barbiturate developed in the 1930s, became the standard induction agent for decades because it entered the brain so quickly. A patient's eyelids would fall, the world would recede in heartbeats, and an endotracheal tube could be placed while the lungs still flexed somewhat predictably. The reason was pharmacokinetic and pharmacodynamic. Thiopental's lipid solubility drove it into the central nervous system rapidly. Then redistribution of the drug into muscle and fat allowed an apparent recovery of consciousness even when elimination had not completed. Its downsides were known and serious. Barbiturates depress the cardiovascular centre. They blunt respiration. They are cumulative. The fine judgment required when dosing thiopental was, in another sense, the profession's apprenticeship. The mid to late 20th century brought new molecules with different temperaments. Ketamine arrived as dissociative anesthetic with an unusual promise, profound analgesia and a trance-like state in which airway reflexes often remained partially intact, and sympathetic stimulation typically increased heart rate and blood pressure rather than depressing them. Developed in the 1960s, ketamine found its role in field anesthesia, emergency medicine, and in patients for whom hypertension would be catastrophic. Side effects, vivid emergence phenomena, hallucinations, the occasional postural nausea, taught clinicians to pair it with benzodiazepines when necessary. Then came propofol, a smooth, modern carrier of unconsciousness, introduced clinically in the late 20th century. Propofol produced rapid, pleasant-sounding inductions, with quick, clear-headed recoveries that made outpatient surgery practicable on a scale previously unimaginable. It was also mercilessly hemodynamic. The rapid loss of arterial tone could plunge a fragile patient's pressure, and like all anesthetics, depressed the drive to breathe. What in these decades changed was not only the list of available drugs, but the framing of how unconsciousness itself was understood. The old Meyer-Overton idea, that potency correlated with lipid solubility, was useful as a broad observation, but later work made molecular targets visible. GABA-A receptors became recognized as crucial loci, where many intravenous and volatile agents exerted inhibitory influence. Barbiturates, propofol and benzodiazepines enhance GABAergic inhibition. Ketamine antagonizes NMDA glutamate receptors. Xenon and other gases touched other molecular switches. Electrophysiology and molecular biology unfolded together, revealing that anesthetics modulated ligand-gated ion channels and voltage-dependent currents, reshaping neuronal network dynamics, rather than simply smothering brain tissue in a chemical fog. The picture that emerged was of a brain whose coordinated rhythms, thalamocortical loops, cortical synchrony, the slow waves of sleep, were gently or not so gently altered by drugs to produce unconscious states that were pharmacologically orchestrated and, crucially, reversible. All the while, practical questions of dosing and safety demanded attention. Anesthesia moves at the rhythm of seconds and minutes, and induction is a choreography of bolus and breath and tube. The mid-century introduction of conceptually modern pharmacokinetic models allowed clinicians to predict concentration time profiles and to design infusions that could maintain steady-state levels without overdosing. In the 1980s and 90s, target-controlled infusions and mathematical models, Marsh and Schneider models among them, made it possible to automate some of that choreography, handing to a pump a desired plasma or effect site concentration and, for a time, allowing a steadier course through sleep. Monitoring technologies too matured. Pulse oximetry, popularized in the 1980s after Takuo Aoyagi's invention of a reliable photoplethysmographic device, and capnography for end-tidal CO2 founded a new baseline of safety. Later still, EEG-derived indices such as BIS promised to quantify depth of anesthesia in real time, though their signals remained appropriately part of a larger clinical picture and never the sole arbiter. The tension between speed and safety is the quiet plot of these years. Rapid onset drugs minimize the interval in which airway reflexes are vulnerable, and a patient may move, but speed amplifies the need for anticipatory airway control and for reliable ventilation. Longer-acting agents provide a buffer, but risk prolonged recovery and respiratory depression in the recovery room. The response has been to build redundancies, better monitoring, better airway equipment, protocols for reversal agents, explicit training in difficult airways, checklists that prefigure the modern safety culture. The advent of Sugamadex, a cyclodextrin that selectively encapsulates immunosteroid neuromuscular blockers and reverses their effect quickly, is a technological tonic, a reversal of paralysis so efficient that it alters the calculus of drug choice. It is, in a way, a modern commentary on the old lesson: every power to paralyze must be paired with power to restore. The century's pharmacological discoveries also rewrote theatre logistics at a grand scale. Outpatient surgery became a possibility because short-acting drugs allowed the patients to leave hospitals in the same afternoon. Anesthesia machines and ventilators shrank and became portable. Sedation protocols for endoscopy and interventional radiology spread the anesthetist's skill into new arenas. Intensive care units absorbed the ventilatory techniques that anesthesia perfected, and ventilators once used to keep polio victims breathing became tools for perioperative support. The discipline of anesthesiology itself widened its reach. Acute pain services, sedation teams, perioperative medicine. All of these grew from the need to understand and manage the drugs that could put the human brain into and out of unconscious states reliably. Underlying all this was a growing humility about mechanisms. Early metaphors, oiling the brain, dissolving the mind into solvent, gave way to a more nuanced appreciation of networks and receptors. Scientists came to see anesthesia as a perturbation of global and local neuronal circuits, an action at the crossroads of chemistry and geometry. The same molecule might quiet a spinal reflex while changing cortical rhythms in ways that were measurable on EEG, and different combinations of drugs could be tuned to maximize safety and minimize the patient's time as a fragile object under the surgeon's gaze. The Boltzmann curves of dose response, the pharmacokinetic models of central compartment and effect site, the context-sensitive half-times for infusions, these mathematical tools made possible an artistry of dosing that, even in the hands of a gentle clinician, looked like math. And the ethical dimensions deepened. Awareness under anesthesia with preserved paralysis became a spectre hospitals could not ignore. The field responded with better monitoring and with standards that emphasized analgesia and amnesia, not merely muscle immobility. The patient's voice, sometimes literally muffled in reports of awareness, began to resurface in debates about sedation depth, informed consent, and post-operative cognitive dysfunction. As the mortality associated with anesthesia fell dramatically through the 20th century, attention turned to the subtler outcomes: delirium in the elderly, post-operative cognitive decline, and the nuances of pain control that shaped recovery and quality of life. So, from the small, precise drops Carl Koller placed on a cornea to the cocktail of hypnotic, analgesic, and paralytic agents that modern teams orchestrate in minutes, the arc of regional and intravenous anesthesia is a study in restraint and empower. Regional blocks taught clinicians where to apply silence and how to confine it. Curare taught them how to separate movement from consciousness with surgical ruthlessness, and when coupled with reliable ventilation changed the very texture of operative possibility. Intravenous agents taught us how to enter and leave unconsciousness rapidly and with some grace. Each advance made possible new procedures, new scales of operation, and new expectations about who could be safely operated upon. Each advance demanded new safeguards: anatomical knowledge, airway mastery, pharmacological humility, and a willingness to add monitors and protocols. If you trace the white lines that surgeons make on skin, the quiet tremor of a syringe that deposits a local anesthetic, the brief injection that sends an anesthetic into the vein like a messenger to the brain, you see a century's negotiation between risk and benefit writ small. There were triumphs and there were costs. There were the occasional tragedies that taught technique and restraint better than any manual could. There were the quiet nights when a mother's labour was made bearable by an epidural, the afternoons when an elderly patient walked out of the hospital after a hip repaired under a spinal, and the many small recoveries that accumulated into a public sense that surgery was less to be feared. By the century's close, the conversation had spread beyond the operating theatre into the laboratory, where neuroscientists peered at thalamic oscillations and anaesthetic binding pockets, and into the ward, where intensivists, surgeons and anaesthetists negotiated the timetables of recovery. The field became interdisciplinary almost by necessity. Chemistry and physiology, engineering and statistics, bedside vigilance and pre-operative planning. Anesthesia ceased to be a trick of drugs alone and became quietly a systemic art. It is in this convergence of molecules to minds, of techniques to theatre logistics, that the history of anesthesia resides. A story of how one century moved from accepting pain and its bureaucracies to taming it at many scales, always mindful that the power to silence sensation and arrest movement is also the power to put life on hold, and that the oldest duty of the person at the head of the patient is not merely to make surgery possible, but to bring the patient back. So we come at last to the present where intravenous agents, barbiturates, ketamine, propofol and their modern cousins stand side by side with regional techniques and neuromuscular blockers in a kind of operational harmony. Our understanding is deeper now. We know receptors, we model kinetics, we measure oxygen saturation and end-tidal carbon dioxide, and yet the fundamental art remains. The drug must be chosen, the dose tailored, the airway secured. The human body, with its idiosyncrasies, still offers its surprises. And for all of the machines, the equations, the elegant molecules, the quietest part of the story is that of people learning to trust one another in the dim theatre light. The surgeon at the incision, the anaesthetist at the head of the patient, the nurse watching the monitors, all of them guardians of a fragile passage. They do not banish risk, but they bend it downward, with steady hands, with science, and with the kinds of small mercies that have, across a century, turned operations that once required desperate courage into things that can be planned, performed and survived with grace. John Snow's inhalers began as the delicate instruments of a Victorian empiricist who treated anaesthesia like clockwork and weather, whose notebooks recorded not only doses, but the rhythm of respiration and the tremor of a pulse under chloroform, and who, by mid-century in London, carried a small brass apparatus that measured and blunted, rather than drowned. His apparatus smelled faintly of cloth and spirit, was forgiving of hands that had not yet learned the newer math of concentrations, and carried with it the confidence of a man who had watched a patient's breathing slow and then settle as if listening to a lullaby. He taught that unconsciousness could be coaxed and timed, that vapour could be shepherded with judgment, and that the instrument could be an extension of the clinician's ear and eye. Joseph Clover, later in the century, tightened that relationship between body and device. A Londoner equally fastidious, Clover made practical attachments and clever valves. His inhalers and devices, refined through the 1870s and 1880s, tried to remove caprice from dosing and to keep a hand on the door between life and absence. These were still essentially artisanal machines, brass and glass, lap-warmed by the theatre lamps, worked by experienced fingers, but they were crucial steps away from pouring ether on a sponge and toward the idea that a measurable, repeatable instrument could stand between a surgeon's blade and a patient's mind. The slow march from handheld inhalers to the bedside machine happened not through a single eureka, but through 100 small mechanical negotiations, a valve here, a meter there, an idea borrowed from chemistry, an idea pilfered from industrial gaswork. In the United Kingdom, in the middle of the First World War, Henry Edmund Gaskin Boyle took the principle of continuous flow and made it plain and serviceable at the surgeon's elbow. Boyle's machine, arriving into the practice around 1917, put cylinders, regulators, flow meters, a reservoir bag and a straightforward breathing system in a single-wheeled cabinet that could be pushed to the patient. It had the hushed authority of varnished wood and polished brass. It made the administration of oxygen, nitrous oxide and ether vapours less an art than a repeatable technical process. Across the Atlantic and a little earlier, James Taylor Gwathmey and a small cohort of American innovators were drafting their own visions. Rotameters and manifolded cylinders, valves that could be turned with gloved hands, attachments to measure pressures. The machine began to look like an organ, pipes for gases, a bellows for breath, regulators that hummed like bellows. But it was an organ that inhaled and exhaled for human beings, and somebody had to learn its grammar. Precision mattered. Flow meters, the glass, often conical tubes with a spinning or floating indicator, later called rotameters, let the anaesthetist see litres per minute climb and fall. Vaporizers turned volatile liquids into controlled atmospheres. First the crude saturators, then the temperature-compensated variable bypass devices that could deliver reliably the now sophisticated halogenated agents emerging in the mid-20th century. The engineering breakthroughs that mattered were usually small and practical. A thermostated chamber so that halothane's vapour pressure would not wander with the heat of the day. A bypass valve that allowed a fixed proportion of fresh gas to sweep through an agent chamber, rather than relying only on a volatile liquid's immediate evaporation. A keyed filler port that would not permit the wrong agent into the wrong reservoir. Patents followed patent-minded clinicians and companies eager to make anesthesia reproducible the way candy factories make lozenges reproducible. Not because chemists suddenly loved surgery, but because managers and engineers loved that one could design a dial and mark it in numbers, and thereby transfer trust from a particular hand to a standardized instrument. This mechanization meant something as practical as an early morning in an operating suite with a new trainee watching the wheel-mounted machine breathe in measured oxygen while the senior operator gently turned a vaporizer dial and the numbers promised, in that rectangular, rational way, what the patient would receive. It made dosing reproducible. It also reduced some kinds of error. When oxygen supply could be piped, when cylinders came with physical keys, the pin index and later standardized connectors that ensured oxygen cylinders could not be screwed onto the yoke, meant for nitrous oxide, the theatre became less a place of improvisation and more a place of controlled variables. Fail-safe devices were added like blessings. Oxygen failure alarms that screamed when the pipeline pressure fell. Proportioning devices that made it harder to give a hypoxic mix. And finally oxygen analyzers that told you in percentage terms what the patient drew in. These were safety checks knitted into metal, mechanical priests that would not be moved by fatigue or ego. Industry moved quickly to answer the demand for standardization. Draeger in Germany, already an industrial supplier of breathing apparatus since the late 19th century, began producing anesthesia equipment on a professional scale. In the United States, small companies and hospital workshops built flow meters and vaporizers. Clinicians patented clever traps for vapor. Others patented assemblies that linked gas flow with mechanical ventilators. The patents are not romantic in the way of poetry. They are mostly drawings and claims and precise arithmetic. But they encoded a cultural change. Dosing was no longer the sole province of memory and feel. It could be passed on by drawing a dial. That transfer, from private skill to public instrument, reshaped the social architecture of the operating room. A theatre could staff itself with trained technicians who knew how to prepare a boil or a Gwathmey, to check the flow meter for leaks, and to replace the soda lime and the absorbers. Reproducibility scaled. Anesthetic dosing could be written down as a plan, and, with a well-kept machine, begun as planned. Mechanization did something else. It extended the reach of anesthetic practice beyond quick, short operations into longer, more complex procedures in which ventilation and oxygenation mattered as much as the scalpel. Mechanical ventilators moved from the realm of pulmonary specialists into the hands of anaesthetists, who now found themselves, in the interwar and immediate post-war years, also custodians of breath. The respiratory needs of children, the frail elderly, the wounded with chest injuries. These invited devices that could take over tidal movements for hours or days. The earlier iron lungs of the 1920s and 1930s, the negative pressure ventilators of Philip Drinker and Louis Shaw in Boston in 1908, had a particular humming presence in wards during poliomyelitis epidemics. Later, positive pressure ventilators, bellows and piston designs that more closely resembled the rhythm of manual bag ventilation were integrated into the anesthesia machine to deliver precisely controlled breaths during surgery. Those machines made the anesthetist's role more technically demanding and more central to the patient's survival. They were, in a quiet way, revolutionary, and the revolution accelerated when the world went to war. The two world wars of the 20th century are most often thought of for their terrible calculus of armaments and loss. For anesthesia, there was another calculus, quieter but transformative, of scale and logistics. The First World War threw skilled clinicians into field hospitals and surgery tents where resourcefulness met volume, controlling hemorrhage, preventing infection, and keeping men under long reconstructive procedures demanded more reliable anesthetic solutions than a sponge and a bedside lamp. Mobile apparatuses, lighter cylinders, wheeled cabinets, simplified vaporizers were preferred because battlefields required men and machines that could move. Henry Boyle's machine, robust and mobile enough to be pushed to the field, found wide and pragmatic use in military hospitals. The wartime impulse was to standardize what worked, to mass-produce what was durable, and to collect and publish operating lists that recorded anesthesia times, drug choices, and complications. Those lists, grim but instructive, migrated into post-war civilian practice as manuals and curricula. The Second World War amplified the effect. Pain management on a massive scale, triage and evacuation systems, and the logistics of resupply under threat demanded a networked industrial response. Anesthetic drugs and equipment had to be produced in quantity, packed for transport, and used by clinicians with a minimum of specialized training in austere circumstances. The mass production of barbiturates and benzodiazepines, the scaling up of thiopental as a fast intravenous agent in the 30s and 40s, the ready availability of blood products and, crucially, antibiotics such as penicillin mass-produced in the 1940s, all combined with mechanized anesthetic delivery to change the calculus of survival on the battlefield. A man who would have died of sepsis in 1918 might survive in M45 simply because a steady supply chain of drugs, transfusion capabilities refined in world wars, and disciplined anesthetic care could be brought into the mobile tent or the forward hospital. A notable human figure in this transition was the anesthetist who learned to work under fire and then brought those efficiencies home. Military anesthesia demanded protocols, induction by a small set of intravenous agents, rapid airway control, oxygen delivered via reliable machines, and an ethos of reproducibility that could be taught quickly. After the wars, surgeons returning to peacetime practice wanted the same dependability. They wanted teams. The modern operating theatre, a room with oxygen piped in through a ceiling, with an anesthesia workstation sitting beside the head of the patient, with monitors that showed pulse and rhythm and oxygenation, with a scrubbed nurse and a circulating nurse and a technician who could spin up suction and warmed fluids, is an institutional air of the military tent. It is more than a migration of hardware. It is a migration of logistics, of checklists, of inventory management, of ways to train a shoal of hands to do the same procedure reliably at scale. The wars also reshaped the workforce. Shortages of doctors in the field and in peacetime hospitals led to a pragmatic delegation of duties, and nurse anesthetists and technicians became indispensable. In the United States, figures such as Alice McGaw, who practiced at the Mayo Clinic around the turn of the century and wrote methodically about outcomes with ether anesthesia, and Agatha Hodgins, who in 1915 established the Lakeside Hospital School of Anesthesia in Cleveland to train nurses, had already laid the groundwork for nurse anesthesia programs. Wartime needs simply accelerated a trend. Trained nurses took on larger anesthetic responsibilities, and in rural areas especially they became the backbone of surgical care. Their legal status and professional recognition were hard-won through decades of negotiation with physicians and hospitals, sometimes combative, sometimes cooperative, and always pragmatic in the face of demand. Out of the machines and the wars came another institutional invention, the intensive care unit. The story most commonly told begins in Copenhagen in 1952, during a horrific poliomyelitis epidemic when an extraordinary Danish anaesthetist, Bjorn Ibsen, proposed an unforgiving idea: tracheostomies, positive pressure ventilation and prolonged respiratory support for large numbers of patients, and organised students and staff into teams to provide manual ventilation around the clock when mechanical ventilators were inadequate in number. His work reduced mortality dramatically and catalysed the concept of a unit dedicated to monitored ventilatory care. The anaesthetist's expertise with airway control, drug-induced respiratory arrest, and ventilators made them natural leaders in these early intensive care units, and the machines that could deliver controlled breath became the centrepiece of a new domain of hospital medicine. Intensive care was then no longer a side project of surgery. It became a specialty in its own right, but forever bound to the skills and machines of anaesthesia. Professionalisation followed technology and logistics. In the United States, the American Society of Anesthesiologists, founded in 2005, slowly matured from a club of practitioners into a professional body that set standards, gathered data and adjudicated training. In Britain, the Association of Anaesthetists of Great Britain and Ireland, formed in the early 20th century and gaining strength between the wars, pushed for training and recognition, and after the Second World War the Faculty of Anaesthetists of the Royal College of Surgeons was established in 1948, later becoming the Royal College of Anaesthetists. Internationally, the World Federation of Societies of Anesthesiologists, founded in 1955, linked practitioners across continents and carried a message of safety and training into low-resource settings. Residency programs lengthened and standardized through the middle decades of the century. Board certification became a gate through which the new physician anaesthetist passed, and universities and hospitals created departments and chairs in anesthesiology, supporting research in the slow accrual of shared knowledge. Anesthesia was no longer what one did before a surgeon made an incision. It was an intellectual and practical discipline with its own theories, its own laboratory methods and its own journals. That intellectual life changed the content of training. Where once the skill most prized was the ability to keep a patient asleep yet breathing, training now included pharmacology of newer intravenous agents and neuromuscular blockers, physiology of oxygen transport and blood gases, mechanics and mathematics of ventilation, and later, the subtle physiology of the neonatal lung and the pregnant uterus. Subspecialties emerged because surgery fractured into specialties that demanded particular anaesthetic knowledge. Pediatric anaesthesia, developed as infants and children, were no longer operated only in desperation, but for congenital corrections. Cardiac anaesthesia grew after John Gibbon's heart-lung machine made open-heart surgery feasible in 1953, producing a need for anaesthetists adept at managing cardiopulmonary bypass and its physiological peculiarities. Obstetric anaesthesia blossomed with epidural and regional techniques that required skillful balance between maternal comfort and fetal well-being. Neuroanesthesia, transplant anaesthesia, pain medicine. Each demanded additional training and eventually fellowship certification. The specialty, therefore, matured both by depth and by breadth. Nurse anaesthetists likewise moved through a parallel process. They built formal schools, lobbied for certification and licensing, and became essential providers, especially in areas where physician anaesthetists were scarce. In many countries, this caused disputes over scope of practice. In others, it led to pragmatic hybrid models where physician anaesthesiologists and nurse anaesthetists worked in teams with clearly defined responsibilities. The story is not uniform across borders. In some countries, the anaesthetist remains exclusively a physician. In others, nurse providers are central to service delivery. What is uniform is this: the growth of mechanism and standardization in anesthesia required new categories of trained worker and a new way of distributing responsibility that matched the scale of modern hospitals. Professionalization also meant systematizing safety. The mid-century introduction of continuous monitoring, of courses on resuscitation and airway care, and later the adoption of pulse oximetry and capnography as standard monitors in the 80s, imposed a discipline of measurement. Oxygenation and ventilation were no longer guessed at by chest rise or the colour of a patient's lips, but observed in numbers and waveforms. The pulse oximeter, born out of work by Takuo Aoyagi in Japan in the Motsi, and the capnograph became as commonplace on the anesthesia machine as a scalpel on the surgeon's tray. Hospitals evolved policies, preoperative assessment clinics, timeouts and checklists, morbidity and mortality conferences where complications were dissected not to allocate blame but to learn. Journals proliferated and specialty meetings grew. The clinical questions of the field, whether a new volatile agent shortened recovery times, whether an analgesic regimen reduced pulmonary complications, were debated and tested. The result was measurable. Anesthesia-related mortality, once a significant fraction of perioperative deaths, fell dramatically in the latter half of the 20th century. The exact figures are a long conversation with epidemiologists. The simple truth is that anesthesia became safer and that safety was purchased by standardized training, better machines, and ubiquitous monitoring. The international scientific community tightened its threads. Societies and conferences carried ideas across oceans. A ventilator design seen in a British operating theatre could be discussed at a New York meeting and modified in a German workroom. A training manual from a US hospital could be translated, adapted, and used to train technicians in India and nurses in Nigeria. The World Federation and national societies facilitated scholarships and training missions. In places where pipelines could not be installed, simpler devices and scavenging solutions were taught. There was a moral turn in professional organisation as well as a technical one. Anesthesiologists recognised that their skills conferred a social responsibility to bring safe anaesthesia to places where it had been unreliable, and professional bodies increasingly included global outreach in their mandates. Across the century, the anaesthetist's role elongated. The person at the head of the patient before the scalpel became a perioperative physician who assessed risk, optimised chronic disease preoperatively, controlled pain postoperatively, and sometimes managed intensive care units for weeks at a time. The profession matured into something that combined physiology, pharmacology, engineering, and logistics. That maturation had bureaucratic consequences: curricula, examinations, continuing education requirements, credentialing for hospital privileges, and quality assurance programs. It also had cultural consequences. The anaesthetist, once a shadowy figure who put people to sleep, became a visible and respected specialist in modern medicine, often heading units and departments. And yet, for all the mechanisation and the international conferences and the layered certifications, the theatre still contains the hum of the human. Machines beget checklists and alarms, and an expectation of reliability, and they also beget new vulnerabilities. An electronic monitor can fail, a vaporizer can be filled with the wrong agent if a key is defeated, a scavenging system can be misrouted, leaving staff exposed to waste gases. Occupational health concerns rose in the later 20th century as studies suggested that chronic low-level exposure to agents could harm staff. Scavenging systems and workplace standards grew out of those worries, and the design of operating rooms incorporated ventilation and capture systems so the anaesthetic atmosphere would be less a silent hazard and more a controlled laboratory space. Engineers and clinicians worked together to make systems that remembered for us when we were tired. Alarms were not only warnings, but a cultural insistence that human fallibility be buffered by an architecture of fail-safes. By the end of the 20th century, the picture that began with Jon Snow's brass inhaler had become both intimate and industrial. The bedside machine, born in the hands of lone innovators, had become an integrated piece of hospital infrastructure. Colour-coded pipelines above the operating table, a wheeled anaesthesia workstation with flow meters and vaporizers, and an attached ventilator and monitor, safety systems and scavenging ducts, checklists and standard operating procedures. The surgeon still slices, the anaesthetist still tends to sleep and breath, but both now do so inside a choreography invented over a century and more. A choreography of engineers and clinicians, of wartime necessity and peacetime standardization, of nurse training schools and professional societies. The mechanisms are not cold. They are the accumulated warmth of countless small improvements carried out by people who learn to measure, and then to teach. If one listens in a modern operating suite late at night when the corridor lights are low, one hears a soft hiss and a gentle rhythm. The machine's bellows, the monitor's measured beeps, the low conversation of a team that trusts its instruments. There is history in that sound. There is the memory of chloroform on a sponge, the clack of an early rotameter, the wheeled cabinet that once rode across muddy encampments, the massed production plants that turned out drugs for a world at war, and the nurse trainers who taught others to keep watch. The history of anesthesia is not simply the story of drugs and vaporizers, but of systems and standards, of logistics and scaling, of professions that learn to codify judgment into dials and protocols. The machine took over some of the memory. The clinician kept the judgment. Together they remade surgery, and in so doing remade a good deal of modern hospital care. The story of safety in anesthesia is, in the end, the story of seeing what had always been there but had not yet been noticed, of turning the operating room into a space where the human body's whisper could be heard through machines and rules until the whisper no longer meant catastrophe. For a century, the instruments of observation crept into hospitals like patient-efficient insects. Riva Rocci's cuff in 1896 wrapped a limb in rubber and gave the first crude number for arterial pressure. Nikolai Korotkov in 1905 taught clinicians to listen for sounds that turned that number into a rhythm. Willem Einthoven, writing early in the 20th century and awarded the Nobel Prize in 1924 for his string galvanometer, gave the heart its orthography, a way to trace electrical language on paper and later on screens. These were not fireworks, they were magnifying lenses. They made the once opaque body legible. The transition from intermittent palpation and intuition to continuous instrumented vigilance happened slowly and then all at once. In the age before monitoring, a pulse was a story told by fingers, blood pressure a number taken by hand and imagination, the heart's arrhythmia read after an event. But as surgery grew in scale and ambition after the wars, in cardiac theatres in Boston, London and Zurich, where surgeons repaired valves and grafted arteries in the 1950s and 60s, the need for continuous information became unbearable. Arterial lines, catheters threaded into the radial artery, went from rarity to routine in major centres, converting blood into a live graph. Continuous pressure tracings for the first time allowed anesthesiologists to watch perfusion in real time to tell the difference between a failing pump and a light anesthetic as the graph flexed and fell. The move to put an arterial line in a patient was elegant and mechanical. It was also brave, because it asked clinicians to trust glass, mercury, and sterile technique as allies against the corporeal unknown. Electrocardiography migrated from the hospital basement to the bedside through the mid-20th century. Early operating rooms took on a new look, leads taped across a chest like a constellation, a short, urgent hiss of paper as the ECG printed a ribbon that could mean the difference between a recoverable arrhythmia and sudden death. EKGs taught anesthesiologists what drugs might provoke and what a heart on the edge looked like, and they allowed teams to correlate rhythm with blood pressure and breathing. These were feedback loops in their simplest form: see, decide, act. But before the 1970s, their speed and fidelity were limited. It is no exaggeration to call the pulse oximeter the single most democratizing monitor of modern anesthesia. The idea, measuring oxygen saturation non-invasively by analyzing light passing through perfused tissue, was not new, but Takuo Aoyagi's insight in 1974 at Nihon Koden in Japan made it practical. Aoyagi noticed that the pulsatile component of arterial blood could be separated from static absorbers, and that by measuring two wavelengths one could calculate arterial oxygen saturation. It was a quiet breakthrough lodged in photodiodes and algorithms, and for several years it lived in engineering journals and company labs. Commercial products followed in the late 1970s and early 1980s. Companies like Nellcor and Ohmada took the Japanese principle, ruggedized it, and brought it to operating rooms from Tokyo to Toronto. Suddenly an audible alarm, a high, friendly beep that fell into an ominous trill as saturation dropped entered a new kind of theatre. Surgeons heard it, anesthesiologists heard it, nurses heard it. The room, which had been ruled by sight and touch, now listened. Pulse oximetry changed the dynamic. Before, hypoxemia could be clinically sealed until the last moment. Cyanosis is an unreliable late sign, and in anaesthetised patients the chest was draped and the pupils still. Pulse oximetry gave minutes, sometimes precious minutes, long before tissue became blue. It turned events into processes. The anaesthesiologist could see declining saturation creep across a number of ear and respond. Adjust oxygen flow. Check airway. Increase ventilation. The alarm became a teacher of cause and effect. Vendors made probes smaller, less invasive. Anesthetic standards, organisations, payer committees, and hospital administrators took notice. By the mid-1980s, in North America and much of Western Europe, continuous pulse oximetry in the operating room was moving from luxury to expectation rather than exception. The Anesthesia Patient Safety Foundation, established in the United States in the 80s to champion exactly the kinds of changes that keep patients alive, helped nudge policy, spread education, and translate engineering into public health. Alongside oxygen saturation, the analysis of exhaled gas, capnography, reconfigured how clinicians judged ventilation. The capnogram, a small waveform representing CO2 with each breath, became the most elegant check on whether a tube sat in a windpipe or a stomach. A flat line, shortly after intubation, meant the tube might have wandered into the esophagus. A falling end-tidal CO2 could whisper of pulmonary embolus or airway obstruction. Capnography's principle goes back to mid-century spectroscopy, and by the 80s and 90s, inexpensive infrared sensors and side-stream sampling allowed its routine use. It became standard for any patient with a secured airway and for those on mechanical ventilation. The waveform produced a language surgical teams learned to read, early, rising, slanted, the tiny plateau that meant all was well. With capnography, ventilation became as visible as rhythm or pressure, and clinicians could confirm ventilation continuously rather than by the intermittent human act of auscultation. What made these technologies decisive was not the devices themselves, but the systems that were built around them. Safety in the operating room matured when monitoring was linked to standards, to education, and to culture. The American Society of Anesthesiologists and other national bodies revised their standards for monitoring through the 80s and 90s. Regulatory steps and professional norms moved pulse oximetry and capnography from best practice into expectations. The Anesthesia Patient Safety Foundation seeded research, published practice advisories, and ran campaigns to ensure that the machines were not idle ornaments but active parts of a safety net. Hospitals instituted checklists and protocols. Anesthesia records integrated alarms and trends. A single pulse oximeter beep changed behaviour in ways that a lecture could not. This was also the era in which human factors engineering, a discipline that looks at people and machines together rather than separately, walked into medicine and sat down. Lessons borrowed from aviation, where crews learned that the cockpit is not just pulleys but choreography, found fertile soil in anesthesia practice. Crew resource management, CRM concepts, were adapted to the surgical setting in the 1980s and 90s. Flatten hierarchies, foster explicit cross-checking, make the junior voice as legitimate as the chief surgeons when safety is at stake. Simulation, pioneered for anesthesiology training by people like David Gabbard at Stanford in the 80s and 1990s, allowed teams to rehearse crisis scenarios with debriefing afterward. The operating room was no longer solely a theatre of improvisation. It became a laboratory in which habits of vigilance could be trained, measured and corrected. Alarms too taught a hard lesson. Early monitoring equipment could and did alarm constantly, a symphony of warnings that risked becoming wallpaper. Alarm fatigue became a recognised scourge. If every beep is an emergency, clinicians begin to mute the machine rather than read its language. Human factors researchers and clinicians collaborated to redesign alarm hierarchies, to prioritise urgency audibly and visually, and to reduce false positives. Checklists and standardized pre-induction and pre-incision timeouts institutionalized the habit of shared awareness. They made the anesthesiologist's evaluation a shared artifact rather than a solitary intuition. And data collection, registries, and morbidity and mortality reviews turned anecdotes into empirical patterns, enabling hospitals to learn from every near miss rather than from only the rare catastrophe. The result was statistical and human alike. Over the latter half of the 20th century and into the 21st, perioperative mortality fell dramatically in high-resource countries. When epidemiologists looked back, they found an unmistakable arc: anesthesia-related deaths. Once a common, feared outcome, became rare. The precise counts vary by method and by country, and the reasons are complex: better drugs, safer techniques, refined airway devices, and the sheer decline in halothane's use all contributed, but the role of monitoring and systems cannot be overstated. By the 90s and 2000s, as studies across Europe, North America and Australasia showed orders of magnitude reductions compared with the mid-20th century, and the correlation with increased monitoring was robust. In plain language, giving teams the right information at the right time saved lives. There were canonical episodes that crystallized the causal link. In some hospitals, the introduction of routine pulse oximetry and capnography was followed by a clear fall in hypoxic incidents and unrecognized esophageal intubations. In cardiac centers, where arterial lines had long been routine, the addition of continuous saturation monitoring and reliable alarms decreased the number of emergent re-explorations and arrests. National audits, such as confidential inquiries and registries in the United Kingdom and Scandinavia, documented falling anesthesia-specific mortality, and investigators consistently pointed to the suite of monitoring, better equipment, and improved perioperative teamwork as principal drivers. Those who had watched anesthesia in earlier decades, clinicians who had once measured pulses by touch because nothing else was available, could not have been surprised. The heart, after all, had been trying to speak for years. The machine simply gave it a microphone. When the perioperative death became less likely, anesthesiologists found themselves with time and attention to address other kinds of suffering. The specialty's migration into pain medicine is, in some ways, an obvious pivot. Providers trained in regional techniques, pain physiology and pharmacology were well suited to manage chronic pain, and the decline of anesthesia as catastrophe opened professional space to broaden scope. John J. Bonacker, an anesthesiologist whose work after World War II laid the intellectual foundations for modern pain medicine, had already argued in the mid-20th century for multidisciplinary approaches. By the 70s and 80s, those ideas ripened into full clinics, where anesthesiologists collaborated with physiotherapists, psychologists, occupational therapists, and surgeons. The biopsychosocial model, articulated by George Engel in 1977, provided a theoretical spine. Pain was not only a nociceptive event, but an experience modulated by mood, context, and function. Interventional techniques flourished. Peripheral nerve blocks matured from hand-guided techniques to nerve stimulator-assisted localization in the 70s and 80s, and later to ultrasound guidance from the late 90s onward. Regional anesthesia shifted from an operating room tool to a chronic pain tool. Stellate ganglion blocks, sympathetic blockade, and complex brachial plexus interventions became options for neuropathic pain. Spinal cord stimulation and Norman Shealy's invention in 1967 found new life and better electronics. Patches of electrodes implanted near the dorsal columns modulated pain signals for some patients who otherwise faced relentless discomfort. Intrathecal pumps and implantable drug delivery systems, pioneered and refined through the 70s and 1980s, allowed targeted delivery of analgesics such as morphine with lower systemic exposure. For many individuals with refractory pain, these technologies rewrote life scripts. At the same time, clinics matured by integrating behavioral and rehabilitative approaches. Cognitive behavioral therapy, graded exercise, and occupational reintegration programs became standard parts of many comprehensive pain programs, particularly in Europe and North America. The pain clinic ceased to be merely a place where injections were done and prescriptions renewed. In the better programs, it became a place where function, not merely pain scores, was the target. For patients, the aim was to restore days, not just to reduce a number on a scale. Yet this expansion was not a tidy success story. The same era saw the rise of aggressive opioid prescribing, fueled by a complex mix of pharmaceutical marketing, changing professional norms and policy nudges. The late 90s were pivotal. Purdue Pharma introduced controlled-release oxycodone in 1996, and the device that was marketed as a safe, long-acting option found a receptive audience among prescribers. Campaigns that framed pain as the fifth vital sign and accreditation standards that pressed hospitals to measure and respond to pain created structural incentives to treat pain aggressively. Over time, the volume of opioid prescriptions swelled. For many patients who were suffering, opioids were miraculous in the short term. In too many others, the initial relief deepened into dependence and addiction. Litigation followed as the public health consequences became clearer. Purdue Pharma ultimately faced criminal and civil penalties that acknowledged the role marketing played in the epidemic, and later bankruptcy and settlements sought to reckon with the human costs. Anesthesiologists who increasingly staffed pain services found themselves in an ethical thicket. Some clinicians had become, almost by necessity, responsible for long-term opioid management. Others resisted, preferring to emphasize interventional and non-pharmacologic modalities. Whatever the stance, the profession had to confront uncomfortable truths. Prescribing carries risk. Regulatory and legal frameworks pressure clinicians to be both compassionate and cautious. And the social determinants of addiction mean that some populations bear disproportionate harm. By the 2010s, policy attempts to curb excess prescribing, prescription drug monitoring programs, CDC prescribing guidelines in 2016, tighter regulatory scrutiny, shifted practice. The pendulum swung from liberal prescribing back toward restraint, with a burgeoning emphasis on multimodal analgesia, regional techniques to minimize systemic opioids, and enhanced recovery after surgery protocols that favor non-opioid analgesics and early mobilization. The conflicts are ethical as much as technical. Is it cruel to withhold opioids from a person in severe chronic pain because of population-level addiction statistics? Is it neglectful to continue high-dose prescribing when evidence of harm accumulates? Much of the contemporary debate turns on the balance between individual suffering and collective risk, between long-term outcomes and short-term relief. Public policy has moved toward caution without eliminating need. Clinicians have had to learn not only how to block nerves and implant devices, but also how to manage addiction, to collaborate with specialists in substance use disorders, and to advocate for equitable access to comprehensive pain care. And as the field looks forward, it does so with a blend of technical audacity and ethical caution. Precision medicine arrives at the bedside in whispers and then in waves. Pharmacogenomics promises to tell us which opioids a patient will metabolize into toxicity and which will be inert. CYP26 polymorphisms determine codeine's fate in a way that is clinically relevant, and variants in RYR1 and CACNA1S genes identify susceptibility to malignant hypothermia, a terrifying anesthetic catastrophe whose genetic underpinnings have been unraveled in the late 20th and early 21st centuries. Genomic knowledge suggests a future where drug selection is not only an art and a science, but a tailored prescription on the basis of genetic risk. Yet genetics also raises privacy and consent questions. Who decides what will be tested, and how will the results be stored and used? The promise of fewer surprises collides with anxieties about data and discrimination. Automation and artificial intelligence offer another frontier. Target-controlled infusion systems that model drug kinetics, the Marsh and Schneider models for propofol are among the best-known examples, have already altered practice in parts of Europe and Asia. Closed-loop systems that adjust infusion rates to maintain targets such as the bispectral index or hemodynamic parameters have been piloted and, in some centres, used clinically. The anesthetic becomes partly a feedback algorithm regulated by sensors and controllers. In pilot trials, McSleepy-type systems and other automated controllers have shown that for routine cases, a machine can keep a patient within narrow therapeutic windows. The practical promise is efficiency, reproducibility, and potentially fewer human errors. The ethical questions loom large. Who is responsible when an algorithm makes a decision that harms a patient? How do we avoid automation bias, where clinicians defer judgment to a machine? How do we ensure equity and access to these tools, so that automation does not cement existing disparities? Environmental stewardship has also become a professional concern. Volatile anesthetic agents, long celebrated for their controllability, are potent greenhouse gases. Desflurane in particular carries a very high global warming potential compared with sevoflurane and isoflurane. Nitrous oxide has both greenhouse and ozone-depleting impacts. In Britain and elsewhere in Europe, health systems began to re-examine routine choices in the operating room during the late 2010s. Hospital trusts phased out desflurane from routine use, anesthesia societies published guidance on low-flow techniques, and there was a palpable shift towards total intravenous anesthesia to TIVA, or to fresh gas flow minimization as ways to reduce emissions. This is not merely a technical debate about which vapor to dial, it is a moral argument about the footprint of modern medicine, and it asks clinicians to weigh immediate patient comfort and convenience against planetary well-being. Beyond the high-tech visions and the environmental ethics, the most enduring challenge of modern anesthesia is still access. The Lancet Commission on Global Surgery in 2015 put a fine point on a cruel statistic. Roughly 5 billion people worldwide lack access to safe, affordable surgical and anesthesia care when needed. In large parts of sub-Saharan Africa and South Asia, the ratio of physician anesthetists population is a fraction of what it is in high-income countries. Non-physician clinicians, such as clinical officer anaesthetists or nurse anaesthetists, provide most care. Equipment is scarce. Oxygen, a precious resource, monitoring rudimentary if present at all. The work of NGOs and initiatives like Lifebox, founded in 2011, has helped. Simple pulse oximeters distributed to low-resource operating rooms have demonstrably reduced intraoperative hypoxia incidents. These are the kinds of pragmatic interventions that return us to the heart of the specialty. Sensible technologies deployed with training and respect can do more than an expensive high-tech array if they are absent where most needed. The future will be judged by how well the profession handles three linked demands: to refine technology so that it is safer, fairer and cleaner, to train more people equitably distributed for the global caseload, and to hold the moral line against commodification that sacrifices long-term welfare for short-term metrics. Workforce planning matters. Simulation and telemedicine can scale expertise, but they cannot wholly replace hands-on training. Fellowship programs in regional anesthesia and pain medicine will continue to multiply in rich countries. If the field is generous and smart, it will also export knowledge and appropriate technologies, not simply hardware, to low-resource settings. Task-sharing models, where trained non-physician providers safely administer anesthesia under supervision, will remain indispensable in many nations. Policy and funding will determine whether surgical deserts remain deserts or become serviced valleys. There are also unanswered clinical questions that will define the coming decades. Does general anesthesia in very young children, in repeated long exposures, measurably affect neurodevelopment? Animal studies have suggested vulnerability. Human epidemiology is murkier, and the FDA's 2016 warning about prolonged or repeated exposure in the very young injected caution into pediatric practice. Post-operative cognitive dysfunction in the elderly remains an unsettled field. Is the anesthetic itself culpable, or is the vulnerable brain simply unmasked by surgery and inflammation? The answers matter not only for individual patients, but for how we consent, how we choose agents, and how we design trials that answer these questions without doing harm. Algorithmic tools promise predictive analytics, AI that can warn of impending hypertension or predict post-operative pain trajectories could let clinicians preempt catastrophes. But for all the dashboards and models, the moral centre of anaesthetic care will remain the human relationship, obtaining informed consent, explaining trade-offs, for example between an inhaled agent with faster wake-up and one with lower greenhouse gas impact, and tending to the fears of a person who will soon be asleep and utterly dependent. Technology ought to augment that relationship, not replace it. In the end, the history of anaesthesia is not a series of gadgets and papers, but of a persistent ethical commitment to relieve suffering without inviting new harms, from Rivarocci's cuff and Einthoven's string galvanometer to Aoyagi's photodiode and modern capnographs. The arc bends toward making the invisible visible and the unpredictable preventable. The trade-offs have been real. Progress has opened new fields like pain medicine that brought solace to millions, and in time unexpected tragedies that forced the profession to ask hard questions about prescribing, marketing and social responsibility. The future will require the same courage, to deploy genetics and artificial intelligence with humility, to choose anaesthetic gases mindful of a warming planet, to insist that the safety that has become routine in high-income theatres be a right rather than a privilege. Listen now to the hum of modern monitors and the low, regular beeping that in many places has become a lullaby for surgeons and anaesthesiologists alike. That beep is the echo of a century of learning. It is the sound of feedback loops that teach, and of alarms that, when rightly tuned, call a team to act. It is also a reminder machines do not care. People do. The work of the next decades is to ensure people everywhere hear the same beeps, learn the same lesson, and are given a chance to wake up whole.